Welcome, everyone. Thank you for taking your time out to be here. I'm a part of the American Journal of Surgery STARS Committee. Our overall mission is to make academic surgery more accessible. This virtual seminar series is entitled Roses and Thorns of Academic Surgery. It's an exciting time to be in academic surgery, but sometimes it can appear daunting to reach career goals. And as such, the purpose of this seminar series is to learn from the leaders in academic surgery, hear about their successes, but also their failures and challenges that they've overcome throughout their career trajectory. Hearing this can be reassuring for trainees that are passionate about academic surgery. Additionally, this interactive session serves as a platform to connect with a leader in academic surgery, and an opportunity that is not always feasible during a national meeting, if you can even make it to different national meetings. And so we're incredibly excited to be hosting the esteemed academic leader and surgeon, Dr. Jay. Dr. Jay is a distinguished hepatopancreaticobiliary and complex GI surgeon. Currently serves as the chair and professor of surgery at the Burnett School of Medicine at Texas Christian University, TCU, in Fort Worth, Texas. Dr. J pursued surgical training at the University of Chicago, followed by a liver transplant fellowship at Baylor University in Dallas. Subsequently joined faculty at UT Southwestern, where he spent 8 years in academic medicine. Now, in his role at TCU, Dr. J is the director of GI surgical services at Methodist Richardson Medical Center and serves as the program director for the HPB and Complex GI Surgical Fellowship within the Methodist health system. Nationally recognized for his contributions to medical education and surgical innovation, Dr. J has authored over 150 peer-reviewed papers and book chapters. He holds several leadership positions as well, nationally, serving as the secretary for the America's Hepatopancreatobiliary Association, HPBA, and the chair of the nominating committee for the American College of Surgeons. Dr. J's clinical expertise encompasses a wide range of GI and hepatobiliary conditions, specializing in both robotic and open surgical approaches for pancreatic and liver tumors. His commitment to integrating clinical excellence, research, and education has been instrumental in advancing surgical care and training programs within the Methodist health system. So very excited to have you speak, Dr. J, and thank you for being here. You can take it away.
Thank you so much for having me. I'll go ahead and share my slides if that's okay. Can you see this, Lamaria?
Let's see. Yes.
Okay, perfect. Well, first of all, thanks for that kind introduction. And it's a little daunting because I'm really not a great academic sort of name like, Herb Chen and people like that. But I've tried to bring the best of academics to the private world. And so hopefully this will resonate with some of you that maybe, feeling like the only place to do some of the innovative things that we all want to do is in the ivory tower type of setup. So I think hopefully that is one thing that you'll get from this talk is how to be innovative and in education research and clinical practice. So I title this Innovation and Is It Possible? These are my disclosures. I'm a consultant for angiodynamics, Ethicon, and Certex. This will have no impact on what I'm talking about today. So I always say that I've spent my life's mission trying to be disruptive. And that's sort of to be different, to be proud of being different. I wore a pink suit at the American College of Surgeons and, took a picture and said, this is how a surgeon should look, because I think we need to all be different and be proud of how we are. And but I always say be disruptive, but not destructive. So that's sort of been my motto. I want to be somebody that's a change maker, but I don't want to destroy things. So this is just a picture because I like to throw in a few things to keep everyone awake. This is a T-tube and a bile duct. This is an old-fashioned way of draining a bile duct. And you have to be able to do some of these old things too, rather than throwing them out and destroying them. So these are the areas of disruption that I feel that I've kind of brought to the table in education, research, and surgical practice. So let's talk about each of these. So I think before you do anything, you have to figure out where you're coming from and then figure out where you're going to, because you can't just change the person that you are. You have to come from a place and be the same person moving forward. You can't all of a sudden change. So this is a picture of Sigiriya Rock in Sri Lanka, which is where I'm from originally, a little island just in the south part of India. I mean south of India. Um, my story, and I'm just going to tell you what a little bit about my story and then where you can fit in. So Sri Lanka. Grew up in Africa. This is Victoria Falls in Africa. Went to basically Hogwarts, which was boarding school in England, to in London, and then came over to America when I was 18 years old. My surgical story was also a story of diversity in that I was at the University of Chicago for residency, then did a year of liver transplant fellowship at Baylor here in town in Dallas, was at the UT Southwestern Medical School as faculty for 8 years, and then went into private practice, which was kind of a huge awakening for me as far as, how do I stay academic in the private world? And this was my trajectory, right? So um, I am in private practice, and yet I would say that I'm trying to be as academic as I can be. And let's talk about that. So let's talk about education. Um, and I put this on here just because I want you to know that as a private practitioner, you can still have a voice. You can still make change. And I wanted you to know what is possible just by showing up to the calls and by having ideas. So half of the people that get put on committees never show up. And it's just, I never felt that way or wanted to be that way because I felt so fortunate to be on these committees, right? I was never one of these people that was being recruited for 100 things or being asked and begged to be on things because of my big name. I was the one who was begging to be on these committees, and I was the one that was volunteering for everything. And somehow, before I got to know it, I was the past president of the Fellowship Council. That started out by one position that was given to me by Mark Callery. He gave me a spot as an accreditation person on the Fellowship Council, and I showed up for each of those calls. I refused to not speak up for what I believed in. Before I knew it, I was the chair of accreditation. Before I knew it, I was the president of the Fellowship Council, which accredits half of the non-ACGME fellowships in the US. Um, through the American Hepatobiliary Association, then was able to be on the board of governors of the American College of Surgeons. And, again, I was full of ideas. And, one of the things you'll realize is people steal your ideas all the time. But you know what? So what? I've got 10 other ideas where those came from. Take them. If that's your only idea, have it. Please, I've got plenty more where that came from. So don't ever worry about that because that's what people who don't have ideas do. They steal them. Okay. Um, Somehow I got to be in the leadership of the HPBA. And, I'm on all these other things. Dr. Hassan is on this call, kindly enough, and he has supported me so much with the SSAT and being on the fellowship task force and all of these things. So again, kind of just, feel so fortunate to be able to do all these things. And then locally, education-wise, I'm with TCU, with Methodist. I've had this HBB fellowship. Remember when I went into when I went into private practice, it was like I died. As far as the academic world goes, you are dead. So I searched out opportunities and I reached out to osteopathic medical school in town because I wanted to work with students. And they were so welcoming to me. They were amazing and their students are incredible. So I don't know. I feel like we should be building bridges, not walls. I also got an appointment with the Armed Forces Institute because I wanted to try to help train their fellows. So they send their trauma fellows to me periodically. So when I teach, I always start from this principle, right? Why did the trainee not make this concept their own? And I put a Kelly clamp over here because I like to put my fingers in the hole rather than palming an instrument. And I have to convince them that that's the why I do that is so that I get a greater degree of freedom with my wrist and I don't have to move my arm. So what do I need to do to convince them that this is a understandable or for me works better? And if they don't make it part of their own, then it's me, the educator, that's had the issue. On the HPB front, I've been very disruptive in that there are three ways to train in HPB, right? Surgical oncology, transplant, and then the Fellowship Council HPB way. If you notice subtly, I've put the Fellowship Council way as the greatest overlap because that's the fellowship we have. But remember, I trained partially in transplant. My practice is a lot of surgeonc. So I kind of feel like I'm the roadmap to peace over here for this. Okay. So I don't know. The Middle East isn't looking so great. So I don't know if the roadmap to peace is working. But that's kind of where I see where I fit in here. And as you see, partially trained transplant, practice a lot of surgeonc, and have a fellowship in HPB. And this is kind of a prime picture of you need to know when to operate, meaning this is a high local angio. Do I need to give chemo first? But also how to operate and not being afraid of doing an extended left hepatectomy here. So you need to have the knowledge base, but also the technical abilities that we can really learn from each training track. And this was kind of my highlight of my career was a consensus statement. This is 2014 now, it's 11 years ago. But I got all the stakeholders together. And if you all have a chance, read this paper, you can search it under me. It was really nice. It went through all of the, ways of training and kind of what the best things were. And I'm always just really proud to say that this term HBB, I'm going to take a little bit of credit for, because when I give oral boards now and people say I'd call an HBB surgeon, I'm like, yes, that I had a little something to do with that because I want to define HBB as its own specialty. And, most recently we went through all of these different fellowship types and the benefits of each of these. And again, I mean, this is me, right? I mean, this is Marwan Albaljude, president of the ASTS, from Henry Ford, Adnan Al-Saidi, like Dean of Education at UCSF, Russ Berman, Dean at, and Vice Chair at NYU, Mike D'Angelica, head of the liver service at, Memorial, Ellen Hagopian, she's a professor at University of Toledo, Tim Pollack, chair of surgery at OHSU, and me. Like, I'm like nothing with this huge group of people. But if you just work hard and are energetic, you can get these people together and you can have a voice. And I just kind of wanted to show you the case requirements. This is not really that big a deal for this group, but I just wanted to point out for hepatobiliary cases, 35 cases and other GI cases, 50, and the Surjonc pathway. On the HPB ASTS pathway, there are a total of about 50 HPB cases. And this is the HPB pathway, which is 100 HPB cases and broken up into liver, pancreas, and bile duct with 25 Whipples necessary, or 20 Whipples, excuse me. So my passion has always been, this is on the wall of my son's bedroom. He's now 30, but I still keep this up, even though he's moved out of the house. I love this. I'm so proud that he has three posters in his room. One is Mahatma Gandhi, one is um, um, uh, the Reverend here, and then the other is Obama when he was with his book. And I just think it's, let's build bridges and not walls. And so rather than building silos around the way to train, why don't we build ways to bridge those gaps? So medically and with regard to student education, this will be interesting to you all that are students. We have an LIC, which is a longitudinal integrated curriculum, which is very unusual for our medical school. And so we have an immersion period and then a outpatient integrated curriculum. So this is actually really innovative. And the thing that's really cool is that you start clinical medicine at month 11. So that's really nice from a medical school standpoint. As little in classroom time is kind of what we aim for. We aim for, content framing and case-based. This is just kind of how our LIC works with a half a day of family practice, peds, surgery, OB, and internal medicine. And then you can do other things in your white space. So my LIC students spend half a day with me in clinic and then, a whole day the next week in clinic in the OR. So this is just an innovative curriculum. And I wanted to show this to you because this is innovation too. On the research side, what I've had to do is build this, right? Because this is not a given. At UAB, for example, you have such great research infrastructure that this can all do. So I've kind of got this, we have students, I call them my production factory, and then we have research fellows. We've now had 5 research fellows. Sudeep is our current fellow. I'm really proud to say that Jessica's going to be an HBB fellow at Mayo. Shankar's coming back to us. Joseph Lim is applying for fellowship in colorectal. Muhammad is going to be actually coming back to us in 2 years. My job is to get them to where they need to be. And we have students from our medical school working with us as well as undergrads. Remember, my job is I'd love to have another paper, but that's not the point. My job is to make sure you, my mentee, gets to where they need to be. That's my job. I do this for the trainees. Yes, it's to get out there what we've done well and not well, but most importantly, it's for my trainees so that they can learn how to do research, and second of all, that they can do better themselves. So, and I love it because when you have a busy clinical practice, when you see patients, you know what questions to ask. And this is one of my favorite papers that we wrote. Kevin Lowe wrote this, looking at Ki-67 labeling index actually. And what we found was that, when they have a low Ki-67 in pancreas lesions, that they actually have a very low rate of lymph node metastasis. This was the first paper of its kind to show this back in 2012. Now we know that if your pancreatic tumor is less than 2 centimeters, and if you have a Ki-67 of less than 3%, the risk of nodal metastases is close to 0. So we could actually watch some of those patients. So you can ask the right questions if you see the patients. And this is another paper that one of my trainees looked at with regard to higher risk of death in a data set if people had a conversion from robotic to open minimally invasive esophagectomy. Again, just question, this is not our data set, but this is a national data set. And then this is an interesting paper that we did looking at postoperative pancreatic leak after Whipple procedure, showing that the median time was higher in those patients that had leaks, suggesting that maybe time under anesthesia was important. And this was a medical student wrote this paper showing that in patients that underwent Whipple procedure, that 50% of them had grade 2 or greater fibrosis. So we're operating on patients with underlying liver disease. So again, all of these things are possible in whatever world. Just a story about clinical innovation. This is one of my techs, Dre. I call them Draymond, and John, who's my first assistant, and this is the group in the OR. I learned robotics at age 49. I'm going to be 60 next week, which is killing me. I still like to dress like a 20-year-old and dance like one too, but unfortunately, this is, I might not be able to get up once I drop and once I drop it on the dance floor next Saturday at my party. But clinical surgery, right? I cannot comment unless I have the experience. So I hate it when people give me their thoughts on things when they don't do it. So I want to do things because I want to be able to comment firsthand. And what did we learn, right? So just one thing is robotically, we need to use all arms. So I hate watching robotic videos where one arm is sitting in the corner doing nothing. Those should all be moving. So we came up with a training paradigm where I don't put the fellow bedside or the trainee bedside. They get one or two cases where they learn how to dock the robot, and then they start working. So I give them one arm and I use two. And then if they show me that they're not going to kill the patient by moving the arm all over the place, I'll give them two and I'll take one arm. So, we need to train, and that means giving autonomy and transition of responsibility rather than showing them just to be a assistant bedside. So this was another one of my favorite papers written by Joseph Lim, who's a PGY4 right now. Um, and what he did was he looked at three different kinds of cases: pancreatic duodenectomy or Whipple, distal panc, and Heller. And what he did was he plotted what's called a Kusum curve, which is a learning curve, not just time, but it's a time from the mean. So it tells you as you're learning, comfort, and then expertise. And so this was our learning curve. And you can see for Whipple, we got to comfort around 16 cases, which is crazy quick, right? For distal panc, it was 11. And for Heller, it was pretty much right away. So this was a way that you can use other cases to increase or fasten your learning curve in another area. So what we found was that robotic PD can be learned, but the slope depends on experience on other robotic cases too, and experience with the surgery that you're doing. And so when I started robotics, I didn't want our learning curves to look like this, right? Faculty while the trainee's sitting over here. I just was having a lot of ethical issues around this because how can I be learning while my trainee is hanging tight? I wanted the learning curves to look like this. And that's why I really came up with this using all three arms and, 2+1 paradigm. So the challenges of the instrument: do you have enough volume on the instrument? Do you have enough high volume practice to do HBB cases? What other surgeries can you use to get better on the instrument? And then you have to be, so that's and the surgery itself, you need to know it, and then you need to have experience on the instrument too. And so as we think about robotics, for example, there's a patient, there's experience with surgery, experience on the robot, how to teach and learn, and the difficulty of the surgery. And all of that has to be done with the patient in mind. So I always say be on the robot enough to know the instrument, be experienced enough with the surgery to know the technical aspects, and then use all of your arms. It's like operating with just your right hand. You got to use your left too. Sometimes I think that we have students come out of residency or surgeons come out of residency that have only used their right hand. It is amazing. If you just stop and watch how little people do with their left hand. It's something really to work with. And so robotically, I start with low-hanging fruit. Distal panc as a stapled operation, no suturing. Hiatal hernia is a nice place to start. And then I actually like esophagectomy as a good way to use robotics before getting to Whipple. And then just a word about building a program, right? So this is kind of just the number of cases we do at our institution on the HPB side only. Um, and, we have people travel from all over the place. You can see that 13% of our patients come from greater than 200 miles and several come from out of the country. And these are just volumes with regard to each site. And these are old numbers. I actually need to update these. And these are just some of the places in Texas that we get patients from. Obviously, we get them from the tri-state area too. Not from Alabama as much, though. And then these are some of the other areas. Oh, Alabama's highlighted, so some from Alabama. And then these are my local competition, right? Juliana Testa and I were fellows together. He's the chair of transplant at Baylor. They have a busy HPB practice. Tom Shire's hired me to UT Southwestern. He's at Presby in Dallas. Herb Zay is kind of a world-renowned robotic pancreas surgeon. So we've got to stay alive despite some amazing competition. And how do you compete? Well, it's the three A's, right? Affability, availability, and ability. So I saw, I think, 8 new patients in clinic today. We get them in. We get them in. That's how we win. Okay. We get them in. And this is what I do. Monday clinic, Wednesday clinic, OR 3 days a week. I'm a bit of a nut. Most people operate 2, maybe even just 1 day a week, but I love operating, and I do quite a few big cases on each day. It's one of the benefits to private practice is that the efficiencies of the system are just amazing compared to academic medicine because there's really motivation to be efficient here in the private world. And so this was just, I just put this on when I made the slide. This was kind of a little bit ago, but this is kind of a typical day, robot para with a GJ segment 5 liver section, liver biopsy, XLab, trach, robot para, Zenka's, Kratsky tumor for rectal something or the other, open Whipple, XLab, distal panc, and I can't read this because I've got people in the way, but XLab, it's just a little bit nuts because having this kind of practice is really exhausting, but I love being somebody who does all of these cases. And just a few things, we were able to get our first in the nation HPV Cancer Joint Commission star, and we were the first site visit for the high-risk GI program from the American College. And, it's not about me, it's about this amazing group of people that do such a great job. So just a word for the trainees. I just want to say, if you want to be a chair one day, you've got to start acting like one now. Now, remember, I'm a chair in a distributed medical school. It's not like, being at one of the major ivory tower institutions in the country. But I just want you to know you you are the surgeon that are you the surgeon that cleans the poop on the table when the patient craps, or are you the one that leaves the room? Are you the medical student that's a fourth year that's helping the third years, or are you the one that just kind of lets them flounder? Are you the medical student that's taken the second year that's kind of shadowing aside and says, oh, this is what he's talking about, or this is the anatomy of this area, let me draw it out for you? Are you the first year that's reaching out to undergrads applying to med school to tell them how you got in? Those are leadership traits. If you're not doing that stuff, don't expect that it's going to turn on tomorrow. You've got to start now. You've got to be a leader in every aspect. You've got to be the person that people want to do work for, not have to do work for. You want people, you want everyone around you to say, I want my family member to come to you. That's what I want. I don't care about being the world's most famous person. I don't need the president of the US or the king of England to come to me. I would rather have the guy that lives under the bridge that is told by a friend of his or hers that I'm the person to go to, or my OR nurses. Wow, they send me their family member. They really know me. They know me because they see me at my worst. And if they still want me, I am so proud. That is my greatest pride. So, I would say start acting like that now. Act as a leader now. Come up with ideas. Make this group do things. Show leadership traits in this group. So I would just say that that's kind of my closing words is just remember, are you the patient are you the surgeon that leaves the room when your patient craps on the table or helps clean them up? I want to work with the person that cleans that patient up because that is humility for me. That is who I want on my team. This is my lovely family, and so I just put this in. I had to update this picture because we have a new grandbaby over here, and she's I'm sort of smitten actually. It's kind of changed my life. So thank you all so much for this time, and I'll be happy to take any questions about anything.
Thank you, Dr. J, for that. Yeah, go ahead, Dr. Hassan.
Yes, Imran.
Thankfully, nobody in this audience knows me other than Rohan. So, but you have to. So let me tell you, I'm a bit, just a little bit younger than Rohan, and this is actually not talking to Rohan. It's talking to the group, but and everything that he said is true, and he means it. He's also very humble to not mention that he actually is the incoming president of the HPBA, which of those people that he showed to you, who are all very well-known surgeons, none of them are. So he has achieved what a lot of people want to do in academics, but he's done it with humility and humbleness, and that's what is most remarkable. And that's why he's my friend, and I don't really care if he's the HPBA president or not. So that's just something to know, that you'll hear a lot of people talk about things, but most people, when they talk, they don't do the walk. But he does both. So just take it from me, he's right. Uh,
Thank
Great
you.
talk, Rohan, as always. And actually, this is the first time I've heard you talk, because I'm actually a colorectal surgeon. So I would have never met Rohan if we hadn't worked through the SSAT. So this is a plug for the SSAT also, which is one of the surgical societies, whose president-elect actually is Greg Kennedy, who is from UAB. So it all comes together. But Ron, again, thanks for your insightful words, because I know they're true. But just on reflection, what would you do differently if you could talk to yourself 20 years ago when you started, that you, in hindsight, you may have felt that maybe I could have done this better? And one last thing, just a comment. We talk about academics and community practice. I don't think academics is a matter of zip codes. It's a matter of a frame of mind. And you can be in an academic center and not have the mindset of that, versus you could be in the middle of nowhere, but if you like to think and innovate, you're an academic. So academics is not about where you are, it's how you think. So
Yeah,
thanks
no,
again, Rohan. Great
yeah, thank you
talk.
so much, Dr. Hassan. You're very, very kind, number one, to join, and number two, for the kind comments. And again, for the group, it means the world to me that Dr. Hassan, who I respect tremendously, would say these things about me. It's wonderful. I think when I came out of residency, probably the one thing that was a little bit challenging for me is I wanted to do everything. And I think that in retrospect, having a basic science lab and trying to make that work and also having a busy clinical practice was very challenging. And I wasn't very good at basic science. I really wasn't very good at it. And I tried to do it because I thought that that's what people had to do in order to be successful. So I guess if I had really had the confidence and the courage to say that part of my life is probably something that I cannot do. So maybe let me do something that I enjoy more, because I didn't really love it. I just was doing it because I felt like I needed to do it. Then that would have been probably made life a little bit easier for me. I think the second piece is, and I don't know, maybe this is part of just being the son of a highly driven teacher mother, South Asian teacher mother. Um, I guess I never felt like I really achieved. And that's something that it's within me, because I know, like, if you look at my CV, it looks good, right? But I always I never feel like I've done enough. And I suppose that's good because you're always striving to do more. But at the same time, I think it's sort of kind of a shame. I kind of wish that I could just be content. I look at my wife and she's so amazingly content. And I think it's actually a little bit rude to the greater powers that we respect and love and trust and pray to not be content. So I need to learn that about myself. And it's a personal thing, it's a personal journey. I'm better about it. Uh, but I think most of it is because I want to mentor to you all that whomever you are, whoever you see yourself, what you look like, what you dress like, how you talk, whether you're good at this, that, or the other. I can't throw a ball or overarm. You know, you can still make a difference in the world and you can be yourself. So don't change who you are because I was, remember I started my residency in 1989 and I was told you had to be a jerk to be a surgeon. I mean, I was brought into the program director's office as a PGY2 and remember my visa was tied to my job. So I was going to be deported if I was fired. And he said, "You're a really good doctor, but you're too nice." And I said, "Note to self, you will continue to be nice and you'll be an even better doctor." So I tried to keep that up, but you sometimes have to swim against the current in order to be able to do all of that. So somebody who knows me really well is on the call now, Chana. Dr. Hassan Chana is a medical student with us who's just finished and actually has been on the wards with me, so knows me very, very, very well and knows that I'll hold her to the highest standards. That's the other thing is I never want to give up on you as a student or a trainee because if I lower my standards, I've given up on you. And that's not what I ever want to do. So it drives people's nuts because I'm like, you should be on rounds with me because Chana can tell you, I'm like, what are the urine electrolytes? Like, I'm such a medicine doctor. Like, how are we treating hyponatremia? You can't just operate on this person and not know how to treat this because a surgeon is a thoughtful person, not just a cutter, right, Chana? And so I want you to know all of those things, not just, this. But I'm going to hold you to the highest standards because if I've dropped my standards, I have not done you a service.
So, Ron, one follow-up question. You talked about being a chair and you talked about the basic science research. So, right now, the perception is if you want to be a leader in American surgery, you have to have a lab or have a big research portfolio. What are your thoughts on that? And you think that still holds true, or will that change?
Yeah, no, I think that's a really good question because I personally feel that, like, as a surgeon, you should be a great clinician. That should be number one, two, and three in my own mind. Because I actually see leaders that when you put them on the spot, you really know what kind of clinician they are. Just to give you an example, I was on a big panel and it was kind of a courtesy, like I called it a sympathy talk on, like, oh, we need to fit him in somewhere and we don't know what to have him talk about. So we'll do something. And it was like bile leaks or something to that effect. And then afterwards, as we were on the panel, there were some questions from the audience about what would you do with a post-op bile leak. And I was shocked that these big names talked about taking them back to the OR. And like nobody who does this would ever take somebody back to the OR for a small bile leak post X, Y, or Z. And so that's when you really notice who's really doing the work as opposed to writing the books, because they're like on the spot. You can give the greatest talk and show the greatest videos, but when you're asked about a clinical scenario, you're like, oh my gosh, like seriously? It's like somebody telling you, I always put in a central line to 10 centimeters. Okay, if somebody tells you that, they don't know what they're talking about because you know as well as I do that depending if the 500-pound guy, you're sticking it till it's hubbed, and on the BMI 18 teenager, you're going to do it, but you're going to use different guidelines. So, but I do think it's important to be investigative, Dr. Hassan. I think it's important to look at your own data critically. That's one of the main reasons that I do research myself, is because I think it improves how we practice. So just to give an example, I kind of put my robotic Whipple program on a hiatus for a period of time after the Priapanc 2 study came out of Europe showing a higher mortality, or Leopard 2, excuse me. And so, but then I looked at our data And actually, it was amazing because actually our readmission rate was much lower and the length of stay was lower. So I've revamped our program now based on our own data because I think that that's what I want to do, is to make sure that the purpose of research for me clinically is so that people don't have to make the same mistakes I made. That's how I look upon research. Not that I'm so great, but let's not make the same mistakes. Let's learn from this.
Great, thanks again. One last comment. So you said that you don't palm the needle driver when you and you put your needle and put your thumb through it. So it's a good thing you didn't train at Hopkins, because at Hopkins you're not allowed to do that. You're supposed to palm the
Yes,
needle
yes,
driver, and
I
you're supposed to
know.
bend your wrist that far
I
enough.
I always and maybe some of this is transanal work, Dr. Hassan, because you've got to go like this, right? Other questions from the group?
Good afternoon. First of all, thank you for speaking. And actually, I feel super motivated from what you talked about, especially related as far as you asked to be on this. So show up and be enthusiastic and do the work. Because I definitely was feeling tired today, but I'm here. Um,
Good, good.
so one of my questions was, you said that you felt like you had to initially do basic science. Um, but what was the turning point, or was there like a mentor that steered you towards what you're doing now? Or like, how did you get exactly to this from what you thought initially?
Um, so what happened is it was hilarious actually, as I was struggling in basic science. I knew that I'd done 2 years of research, basic science research, and I knew I could do bad research well. Most surgeons think they can go straight into the lab and do research. Okay. And you realize that all PhDs do 4 years at least of their PhD and then at least another 2 to 3 years of a postdoc before they have their own lab. But somehow we think we're so amazing that we can fast track all of that, right? And so I said, I realized that I could do bad research well. So I wanted to do good research. So I actually was pretty much a postdoc in one of the PhD's labs, and he felt that I was his technician, which was right for a postdoc. So I was there between the hours of 6 and 9 every night because I still had a busy clinical practice. I was pouring gels, I was doing all of my own experiments, all of those things, right? Which was great experience. I actually got 2 small grants funded, and then, and this is, I just did a podcast with the HPB and I mentioned this, and it's so embarrassing, but I actually was having our church prayer group pray for me for an NIH grant. Like, I always tell my kids, don't pray for something specific, pray for God's will, right? And it was so ironic. I got an NIH grant funded, and I left UT Southwestern, so I couldn't take it. So God has a sense of humor, and truly, I should have been praying for his will or her will, not my will, right? And so I'm so embarrassed to say that I actually was asking for this prayer from our church group. So he humbled me, not humiliated me, humbled me. And what I did was I threw my energies into outcomes research because I had the data set from my own work instead of basic science, animal, molecular experiments. And that's what I've done. Now, my desire is, and Dr. Hassan and I can provide tissue, right? My desire is that every piece of tissue that I take out goes to somebody's lab to further things. That has been really difficult to develop, I have to tell you. Even though it seems so straightforward, it is not, because transferring tissue is a whole medical legal nightmare. But that's what I would want, is that every patient that I saw had tissue going to something to make the world better. Okay, because I'm cutting it out anyway. But that's how I ended up with outcomes research. It's through a very funny sense of humor by the big guy. Does that answer your question, Jose?
Yes, sir. Thank you.
My pleasure.
Sharna, did you want to chime in?
Yes, I do have a question. Hi, Dr. J. First,
Hi.
It's so
Great to
wonderful
see
to
you.
see you. This is like my surgical dad. Like, I
It's
would
so
not
good
be
to
where I
see you.
am. I would not be a surgeon right now. I would not
I'm
be
so proud of you, Shauna.
anything without him. So it's
You're
wonderful to
so
see
sweet.
him. It's
Thank you.
wonderful to share him with you all because he drops pearls like he breathes. That's how often they come. They just come and you can just catch them. And true to his word, when I rounded with him, I can say that was my first time thinking, oh, as a general surgeon, I have to think about everything. I'm not just a technician. I have to think about everything on rounds. I got to think, what is going on with the patient as an entire person. And for me, up until I did that sub-I with him, I never really saw general surgeons as that. I thought we were kind of just technicians and we kind of can just, consult medicine or that type of thing. But no, we don't get to I still don't get to consult medicine. That I can't. So it's wonderful to get to have gotten that early on experience with him. Dr. J, could you speak a bit about how you've kind of created just such a thriving kind of hybrid model with your community hospital at Methodist, as well as where you're doing academic work, but your productivity is just, you can't get the productivity that you have, in my opinion, at an academic program because you just have things ran so finely tuned. You have a finely tuned, dedicated staff and things like that. And that's honestly becoming kind of something I want for myself as a surgeon, like especially now being in an academic set. I'm like, yeah, I like the setup Dr. J had. So I would love to know, like, how did you lay the foundation to get that
Yeah.
setup for yourself?
No, thank you so much, Shauna. That's really sweet. And I think it all comes from being a leader, right? And you want people to do their best for the patient. And if you can get that concept across, everyone gets it because most people want what's best for the patient. What we tend to see in academics, and the part that I don't miss about academics is it seemed a lot of times that people were focused on what was good for them. And that's not what we should be doing, right? I mean, this is not about making me famous. This is not about, and things like I said about the research. I'd love to have another paper, but that's not the point. My greatest pride is that every undergrad that has worked with us, bar one who's still trying, has got into med school. Okay, so that's the proof in the pudding. That's my reward. It's not the papers they wrote. It's the fact that they've got to where they want to go to. Every fellow that we've had, as I mentioned, is now in fellowship or going to be in the fellowship of their choice. I have to ask Dr. Hassan for his help with colorectal. That's the only thing for Joseph, who's coming up next year. But I think that people really respond to being appreciated and understanding that it's for the best of the patient. I also think, Shauna, that you have to be efficient in your own life. And from working with me, I'm not afraid to put in that Foley. I'm not afraid to put in the central line. I'll be prepping. I'll be doing anything. Nothing is too much or too little for me, right? I'll be mopping the floor if need be. I'll do whatever that will help the patient, not me, the patient, right? And so one of my funniest stories was at Methodist Dallas when I was down there. I remember it was so inefficient, and the room was ready one day, and they didn't have a transporter to go get the patient. So I said, "I'll go get it." So I wheeled by with the bed and the patient, and there were 4 residents standing at the front desk, and they were like, "What's going on?" And I was like, I mean, nothing should be too good for you. It's what's best for the patient, right? Patient needed to go, we're going to go. So, I think you just do what's best. And I think that runs it. I think this is one thing, though, it was really interesting because I was telling you about this podcast, and one of the things that came across was there's just this inherent despite what Dr. Hassan kindly said about the lines being blurred between academic and community practice, there is just this, how can you do good work outside of ivory tower centers? There's this disbelief that we can do good work. And let me tell you something, these people I work with, they do clinical medicine day in and day out. These cardiac surgeons, they're jumping day in and day out. They're not pulled out of the lab to come do a valve. They want to do this. They're really good at it. One person operates with his left and right hand. I get dizzy. I can't even tell what's going on because he's so good. He does cabbages in 2.5 hours. His pump times are like ridiculous. He operates on the hardest patients ever. How can we let standard academicians know how great the clinical medicine is outside of academic practice? The question I was asked by somebody was, how do you, the concept is that that private practitioners never change the way that they did things after residency. And I'm like, actually, some of the greatest innovations in surgery have been through private practice. Dr. Hassan can tell you about the healed data set from rectal cancer, and he was in a small hospital in London, and he changed the way that we do rectal cancer work by describing the TME. I mean, this was a private practice. I mean, not private practice, but he was in a small community hospital. So there are ways that we can do this. We just need to respect each other, and understand what we have to teach each other. Most of us know what academic medicine looks like, but not many people understand what's good about private practice. And so when you see it, I've actually invited some of the thought leaders, just come spend a day with me, because Shauna, I think it would be eye-opening, right?
So
Questions?
I have a quick question. You talk about innovation and disruption. And so I'm wondering how you can utilize those strategies while leveraging your leadership positions. I'm particularly curious about your leadership positions with like boards of accreditation
Yeah.
and how you might be able to enact change through those platforms.
Oh gosh, you have me. This is like, I have to be really careful because I sometimes think I'm too edgy in the way I think about these things. I mean, one of my big things is visual and non-visual diversity, because you don't know what's going on behind the curtain, right? We've got caught up in visual diversity, which is great. We need to start there, but we also need to look beyond that, right? Because you don't know what people have gone through in their lives, and we need to take the time to understand that, right? And understand that and put that into context, because that should change the way that we frame the issue. So I think some of the ways that we get away from that, just let me give you an example, test taking, right? Okay, gosh, some of us suck at test taking. I'm one of them, okay? And so when we look at certification or reaccreditation, one of the things I'd like to look at is a more holistic approach of that and try to get a sense of, is this surgeon safe? Okay, so why can we not do 360 evaluations? Because I tell you, my nursing staff is going to tell you who's safe and who's not, more than any exam, more than any exam. And so can we not do that? Can we not get other metrics? For example, if one of Dr. Hassan's colleagues is taking 4 hours routinely for a regular right colectomy, that's a problem, right? And so, we need to look at some of those metrics that are not just exam based, because I think we need to do that in all arenas, because we do know that I was actually reading a paper that came out recently on success in residency. I don't know if you guys saw this, but it was really interesting, because if you look at success, the residents that were viewed as successful, it was not correlated at all with USMLEs or even GPA. It was actually non-measurable grit type of things. So, we were talking about, should we be doing a grit scale, because I know some of the people on the call have had such adversity in their lives and yet got to this point. That's the person I want, right? Um, so yes, so I'm disrupting in some of those things to try to change some of the things that are just exam based, for example, okay, to try to see if we have a more holistic approach to that. Um, One of the areas in my specific area that is so, oh, it's such a lightning rod is HPB, because it does have so many facets to it and it's so emotional. I just want to look at it from a data standpoint. I'd like to say, we look at lap chole, for example, and we knew that lap chole bile duct injuries happened around 40. And we promised to get you all as trainees through that number during residency under our coverage. We should do that for colectomy. We should do that for, for Whipples, etc. I know that for Whipple, that number is about 60. Probably we should require that as the inflection point during training for HPB as a reasonable number of cases. So yeah, I'm pushing some of these novel concepts, with regard to trying to change push the needle a little bit more. Not afraid to shy away from being the person in the room that everyone, usually, Lamario, I'm the one that's saying something that everyone else is thinking, but afraid to say. And so I'm like, and that's one nice thing about being in private practice is my promotion doesn't depend on me being president of the next association, right? Like it's time away from stuff. Shauna can tell you the time with my medical students is because I love it. It's not like it's going to win me some huge accolade. It's because I want to do it. How great is that, right? One of my I heard this from a major academician who said, wow, I'm professor now, but I don't really have anything else to work for because I've got professorship. And so that was, that's how you have to think in academic medicine because it is that sort of stepping structure and there's beautiful things about it. I don't want to, I don't want to disparage academic medicine because that's who I am. I think that they're just things that we can learn from each other. And I just want to bring to the table the positives about the other side of things.
Well, I really appreciate you. We're now at the hour. Uh, if there weren't any other questions, burning questions that anyone had, we can go ahead and conclude the evening. Definitely, Dr. J, appreciate you for offering all your wisdom, and just taking your time to speak with us and give us and explain to us your passions and why you do what you do. So definitely appreciate you. And I know I've personally enjoyed hearing from you this evening.
Thank you. And I'm putting all my contact in the chat over here. I'm here as your mentor in any way I can be. I am very approachable. I have done everything wrong in my career that you could imagine. So I don't want you to have to reinvent the wheel, okay? And just remember, I applied for residency with a foreign passport, and most of the programs I went to, number one, well, many didn't even interview me because I didn't have a, a visa, right? And second of all, many of the programs I went to looked at me like I had three heads. So if I can do this, you can do this. Okay? Thank you so much.
Thank you. Everyone have a good night.
Bye.
Thank you, Dr.
Thank you.
J.